Assalamu alaikum warahmatullahi wabarakatuh, dear colleagues and friends. Ramadan Kareem for all of you, and may Allah bless you and your families with goodness and blessings. Today was the result of February exam, so congratulations for those who succeeded in the exam in February, and best of luck for those who were not lucky this time. Please, for those who did not pass, never give up, and be sure that failing in this exam was also a blessing from Allah. It may be a mercy. May Allah saves you from a bigger problem in your life by failing in this exam. So please keep trying until Allah authorizes your success. Please keep this advice in front of your eyes and never give up. Time will come and you will forget all the efforts and all the difficult times that you have passed for the part 3 exam. So today we are going to discuss the preoperative round for the gynae list. Again, this is according to your request. It is a structured discussion case that comes repeatedly in the exam. And today I will try my best to show you how to approach the case during the discussion in the exam. So you will face this scenario as a structured discussion that will assess the patient safety, the communication with colleagues, the information gathering, and the applied clinical knowledge. You will be the ST5 who is doing the preoperative ward round, and you will meet your consultant who will ask you some questions about the list, and during the discussion you should lead the discussion by yourself, and the examiner may ask you some questions and signpost or prompt when required. The agenda in this station will be, you need to show what are the particular risks in each case and how to reduce these risks. Reduction of the risk will be through preoperative optimization of her general condition, then the intraoperative measure, then the post-operative measures that will be done after the surgery, and the final part of the station will be how to put the patient in orders for the list according to the priority or according to the risk in each case. So the station will come usually 4 patients. You will have one major case in the list that usually will need laparotomy. You will have 1 or 2 cases for laparoscopy, and usually you will have 1 early pregnancy failure, either molar pregnancy or missed miscarriage for evacuation. So this is the usual types of patient that will come in the gynae list. How to approach in this station? As usual, my advice, succeed in this station, you have to avoid the failure. So you should know how to avoid the failure in each domain of the domains in this station. So in the patient safety, avoid failure in this station, and to gain the success, you have to mention the patient information leaflet, that the patient already had received patient information leaflet and she knows the different alternative of the surgery, that the patient already signed the consent. In patients in the reproductive age, the pregnancy test is negative. The preoperative investigations were reviewed before the surgery, that the blood was taken for group and safe. If the patient received prophylactic antibiotics, and the WHO surgical safety checklist was used during the surgery, and the thromboprophylaxis if needed. So these are the safety points here. It may not be needed in all the scenarios, in all the patients, but by the end of the station, make sure that you went through all these points in the different types of patients that you will have in the list. So these are the points in the safety. The second is information gathering. What's included in the information gathering in this type of station is your ability to identify the surgical risk in each case and how to avoid these risks. How to avoid the risks? Please be organized, go systematic, pre-operative, how to avoid the risk, intraoperative, how you will change your procedure to minimize the surgical risk, and post-operative, what you will do to reduce the post-operative complications. In any discussion with the examiner, if you feel that the information given are lacking important points that will help you to make your decision, ask for more details. The examiner may provide you with more information that will change your mind or change your plan according to the findings that he will give to you. So these are the points in the information gathering. The next point is communication with colleague. So how to communicate with the examiner is a point that you will be assessed and the examiner will give his feedback on your way of communication with him. So during this station, you should lead the discussion. The examiner may prompt you once or twice, but not more, please. So make sure that you cover all the points in each domain. Don't let the examiner prompt you more than 1 or 2 times during the station. Very important point in communication with colleague is to ask for help. By this point, they know that you know your limitations and you will call for your consultant or other specialties in complicated cases. You need a multidisciplinary team for management of the case. Then the domain of applied clinical knowledge. Here, what are the points that will be assessed is your ability to identify the risk factors in this case, and again, how to avoid these risk factors before, during, and after the surgery. But you have to use an evidence-based approach. This will reflect your knowledge about the guidelines and the recommendations. If there is a procedure, you should explain the advantage and disadvantage of each surgical approach you will be asked during the exam. Ensure, this is a very important point, if you have taken biopsy, especially in cases of early pregnancy failure, please ensure that forms are filled for the samples and biopsies, and these are sent for histopathology. The order of the list is considered as a clinical knowledge, so you know what are the risks and what are the indications for each patient to be in the start or at the end of the list. For some patients, you may need to postpone the surgery or offer her an alternative if not already discussed before. So that's why patient information leaflet is very important to ask about it in this type of station. So many points here you need to mention during the station. During the 10 minutes, you should cover most of these points, not for each patient. So according to the patient, you will mention some points, but by the end of the 10 minutes, by the end of the 4 patients in the list, you should mention all these points during the discussion, because these are the points that will help you to avoid failure in each of the 4 domains that you will be examined in during the station. Before driving, you need to put your seat belt, your safety belt. So the next 7 points are the safety points in each case. So here, these are the safety points, the information gathering, communication with colleagues, and applied clinical knowledge for all the patients, But here you have to mention the next 7 in each patient. So before starting, you have to put your seat belt, your safety belt. What is the safety here? These 7 points are the safety points. If you mentioned these points, you will pass the station definitely. At least if the examiner asked you any questions and you did not answer, most probably you will take a borderline in the applied clinical knowledge, but you will not fail in the station. So what are the points that has to be mentioned before each case in the list? You have to confirm that the procedure is still valid indication for this lady and she has written a consent. So this point, the first point, has to be mentioned before starting discussion of each case. If the patient is in the reproductive age, you have to confirm that the pregnancy test is negative. If there is any special requirement for special types of instruments, you have to mention this. You have to mention the point of antibiotic prophylaxis and the thromboprophylaxis if needed. Each patient, the blood samples has to be taken for blood group for saving or cross-matching. Each patient, you have to mention the WHO surgical safety checklist. And in case of unexpected steps or difficulties, you call for help from your consultant or other specialties. So in each case, please make sure that the consultant is around or he's scrubbed and involved in the case if it is a major and complicated case. So please remember these 7 points. These are, in my opinion, the safety belt or the seat belt when you are going to start driving or starting any case. So all the points has to be mentioned, but these points has to be mentioned specifically in each case. At the end of the discussion, the examiner will ask you to put the patient in orders in the list according to the priority or according to the risk in each case. So, as a general rule, if any pregnant lady is there in the list, she will come first. If there is one-day case surgery, she will come earlier in the list. So this is the general rule. But usually this will not be applicable on the stations in the exam. Why? Because they will put another patients that will have priority in spite that the pregnant ladies or one-day case surgery are there. So what are the cases that will have priority in the list? If you have a case of latex allergy, it will come number 1 on the list, whatever the other patients on the list. So latex allergy, it will be number 1, whatever the other scenarios on the list. If you have a patient who's diabetic on insulin, especially on insulin pump, this patient will be the first on the list unless there is a patient with latex allergy. So again, latex allergy number 1. If no latex allergy and there is a patient who's diabetic on insulin pump, this patient will be number 1. If you have complex cases with major risk of bleeding as cases who are on anticoagulant, these cases has to come earlier on the list because these cases needs a multidisciplinary team. They will need each one to be involved and they need to be fresh in the morning. So these cases may need to be earlier on the list. So again, usually pregnant ladies or one-day case surgery have the priority unless you have one patient with latex allergy or one patient who's diabetic on insulin pump or one patient who has a major risk of bleeding. So the priority will change in these cases. If you have a patient that you know that she needs to stay overnight, but without a major risk factor for bleeding, this case will be laid on the list. So this is how to arrange or to order the patients on the list according to the priority and the risk in each case. So again, a case of latex allergy, what are the steps to reduce the risk in this case? This case, it has to be the first on the list. Again, the first on the list, whatever the other scenarios you have, and preferably to be done on theater which was not used overnight. Why? Because latex allergies are airborne and we have to keep it at the minimum level. So number one, put it number one on the list. You should inform the theater manager. The theater manager will distribute the information for the appropriate staff who are sharing in care of this lady. The anesthetist has to know about the case. We have to ensure that there is availability of latex-free trolley and cart, and there are emergency medications for treatment of anaphylactic reaction if it occurs. Avoid the latex-containing materials, particularly latex gloves, and cover any latex-containing surfaces. Use latex-free anesthetic circuits, face masks, and other equipments, and use latex-free syringes. So these are the measures how to reduce the risk in a case of latex allergy, which, remember, it has to be the first case on the list, whatever the other cases you have. If you have a patient, an insulin pump, this patient will come first on the list. So again, this patient will come first on the list unless there is a patient with latex allergy. Other steps, this patient should have a diabetic care plan by the endocrinologist. This patient needs a frequent check of the blood glucose every 30 minutes during the surgery, especially those who are under general anesthesia. The energy sources will affect the function of the pump. So the pump has to be removed before the surgery if you are going to use energy sources. And another general rule, if the surgery estimated time is estimated to be more than 1 to 2 hours, the pump has to be removed before the surgery, and you have to start sliding scale until the patient will be able to manage their own diabetic care after surgery. So these are the steps for a patient who has an insulin pump. It will be the first on the list unless there is latex allergy, then diabetic care plan, then frequent monitoring of the blood glucose during the surgery, remove it if the surgery will last for more than 1 to 2 hours, and if you are going to use energy sources. So this is the point regarding the patient with insulin pump. You will always find in the scenarios one patient with very high body mass index and another patient with low body mass index. The patient with low body mass index, usually the difficulty will be the difficult entry during the laparoscopy. So in these patients, you will use special type of instruments. You will use small size of the varus needle, and you will go through the palmar point or the open Hasson technique. In obese patients, they have so many risks because of their obesity. So these risks include anesthetic risk requiring long spinal needle if she will have regional anesthesia. They will need also special instruments. They may need all instruments to be of different sizes. They will need more than 2 doctors to do the procedure. They will need more assistance. Again, they will need special techniques during entry by laparoscopy. Again, the palmar point or Hasson technique. There is more risk of infection in these cases. There is more risk of DVT, so they will require thromboprophylaxis post-operative. All other risks, intraoperative and post-operative, will increase in obese patients. So this is the risk regarding the obesity and the risk regarding low BMI. During the discussion, the examiner will come out with questions. These are the most common questions that will appear in the exam. The first question is the entry technique during laparoscopy, especially if there is evidence of adhesion, if low body mass index or high body mass index or previous surgery. So the answer in this question will be, you will go for open Hasson or palmar point technique. If you are going to do diagnostic laparoscopy, the examiner may ask you, if you find endometriosis during diagnostic laparoscopy, will you treat the endometriosis? Please always answer by it depends. Start your answer by it depends. It depends on the consent and the patient wishes before the surgery. So the patient has to be informed about the possibility of see and treat, and she will sign the consent. And it also depends on the degree of endometriosis. So you can treat type 1 and 2 endometriosis at the same setting, but you cannot treat type 3 and 4 endometriosis. This will need more expertise and multidisciplinary team. So type 1 and 2 will be treated after ensuring that there is consent from the patient to treat. But whatever the stage of endometriosis, biopsy is mandatory. You have to take biopsy because the histopathology is the only way to confirm the diagnosis of endometriosis. So this is the answer of this question. Always start by it depends. Another question, if you have a case of hysterectomy, the examiner may ask you, are you going to do total or subtotal? Again, start your answer by it depends. It depends on many factors, including the history of cervical smear. You cannot do subtotal hysterectomy in a patient with abnormal cervical smear. It depends on also on the anticipated difficulties in the history, like example, previous surgery, severe PID or endometriosis. Anticipated difficulties by examination like obesity, for example. Also, it depends on the intraoperative difficulties, like if you have large fibroids or adhesion, you may consider doing subtotal hysterectomy. But the most important is the wishes of the patient after explaining the pros and cons of each one of them, mainly for subtotal hysterectomy. So if you are going to do subtotal hysterectomy, there are advantages. It will have shorter operation time because it is technically easier, less risk of visceral damage in case of adhesion, less bleeding intra and post-operative, and less post-operative fever. So these are the advantages. But what are the disadvantages? So if you will keep the cervix, the patient has to continue on the cervical screening program. This patient may have cyclic bleeding if you kept part of the endometrium and the ovaries are left. This patient, if she will develop cervical pathology in the future, the surgery will be more difficult. And on the same time, there is no evidence that keeping the cervix will have a good impact on the sex or the impact of prolapse and incontinence in the future. So this is regards the total or subtotal hysterectomy. Another question, if you are going to do hysterectomy, will you remove the ovaries? Again, please start your answer by it depends. Again, it depends on the wishes of the patient after explaining the pros and cons of leaving the ovaries. So what are the advantages of leaving the ovaries? The operation time will be shorter, lower risk of heart disease and osteoporosis in the future. So you will delay the need of HRT and its complication also. But the disadvantage of leaving the ovaries, if the patient will develop a pathology in the future like ovarian cyst or ovarian cancer, the surgery will be very difficult. The patient may have chronic pelvic pain and dyspareunia in the future due to the trapped ovary syndrome. So it depends on the patient wishes after explaining the pros and cons. It depends on her age. As the closer the patient to menopause, the more likely you will remove the ovaries. But there is recent recommendation against this in the current time. Also, the personal and family history of cancer will affect your decision to remove the ovaries or no, and the intraoperative findings. So please always start your answer by it depends. It depends on her wishes after explaining the pros and cons. It depends on the personal and family history of cancer and the intraoperative findings. Another question that you will be asked in the cases that you are going to do oophorectomy, the examiner will ask you, are you going to remove the fallopian tubes? Tubes means both tubes. You are going to do unilateral oophorectomy. Are you going to remove both tubes? So at this point, again, it depends. Depends on the fertility wishes of the patient. If the patient wants more children, so you can remove the tube on the size of ovarectomy and keep the other side. But if the patient does not want any future pregnancies, so it's better to remove both tubes if the patient, especially if the patient has past or family history of cancer. After explaining the pros and cons of salpingectomy, why you are going to remove the tubes to avoid the risk of surface epithelial tumors of the ovary, because there is theories that the tubes are the source of the surface epithelial tumors in the ovaries. So again, are you going to remove the fallopian tubes? It depends. Depends on her fertility wishes, depends on the past or family history of cancer, and it depends on the consent that the patient signed before the surgery, explaining the pros and cons of salpingectomy. Another exam question: if you suspect ovarian cancer during cystectomy or ovarectomy, what you will do? Again, it depends on the consent, and it depends on the age. So if no consent, please, even if you find the cancer, don't remove it. Just take biopsy and arrange for another setting after multidisciplinary team meeting. So even if you find malignancy, it depends on the consent of the patient to treat or no, and don't forget to take biopsy for histopathology, then arrange for multidisciplinary team and another setting. So these are the ways how to approach the station. These are the ways how to put the patient in order. And these are the most common exam questions that will appear in each station. So now we are going to take one example from the list, and the other patients on the list will continue in the practice session that I will announce on the group later. So again, here you are the ST5, you did the preoperative ward round, and you are going to meet your consultant now to discuss the cases in the list. All the patients have been assessed by the anesthetist, and they have VTE risk assessment already completed. The examiner wants from you to know what are the particular risks in each case and how to reduce these risks. And what are the surgical approaches and the techniques that should be adopted in each case or in each surgery. And then finally, we will justify the order of the list to be conducted in. So for example, if I'm going to take the first case here, please, each box contains an information that you have to comment about. So here, patient is going for diagnostic laparoscopy, treatment of endometriosis. Laparoscopy is risk. The laparoscopy itself has its risks, starting from the anesthetic complication and going through each step of the laparoscopy. Endometriosis carries risk of adhesion, so the entry will be difficult. The surgery itself will be difficult, especially if it's stage 3 or 4. The age of the patient here is a risk factor. This patient is in the reproductive age, so you have to ensure that you did pregnancy test before taking the patient to the theater. The body mass index is 18, so low BMI, it will make the entry technique more difficult. So in this patient, you may consider open Hasson or Palmer point. This patient, in her notes, she has chronic pelvic pain. Chronic pelvic pain may be due to adhesion, may be due to previous PID, may be due to the endometriosis. So again, this is another risk of adhesion, and you need to avoid this by going through the Palmer point or open Hasson technique. Latex allergy, as we said before, it is risk and has its points. So in this case, how to go? Remember the safety seat belt. So I will confirm that the indication of the surgery is still valid for this patient, and there is written consent. The patient already had a patient information leaflet about her condition, and she knows all the alternatives, including no treatment. I have to ensure that this patient had a pregnancy test and is negative. This patient is very lean, so she may need smaller size of the instruments, varus needle, and other instruments. I have to ensure that the patient already received antibiotic dose for prophylactic antibiotic, and the thromboprophylaxis risk assessment was done. I have to ensure that the blood sample was taken for blood group and safe. I have to ensure that we used the WHO surgical safety checklist before starting the surgery and during and after the surgery. If I find any difficulty during the procedure, I will call the consultant for help. These are the safety points that has to be mentioned. Then you will go through the different risks in this case. What are the possible risks in this case? It will include the anesthetic risk, so preoperative assessment by the anesthetist to avoid the risk of anesthesia. This patient has general risks due to adhesions due to endometriosis and chronic pelvic pain, so we will involve the consultant. There is risk of vascular injury because of low body mass index, so we need a good and safe technique during insertion of the varus needle and the primary port. We may use alternative entry technique like open Hasson and Palmer point. This patient has more risk of bowel injury, so the secondary port has to be inserted under vision, and the careful use of thermal energy. To avoid the risk of infection, we have to do high vaginal swab preoperative. To avoid the risk of cervical injury during insertion of the cannula, it's better for the laparoscope to be done in the proliferative phase of the cycle to avoid difficulties, and the cervix will be still dilated. To avoid the risk of hernia during from the port side, we have to completely empty the abdomen from the gas and to close the port size if it is more than 10 millimeter in the middle or 7 millimeter in the lateral port. Remember, please, that there is possibility of negative laparoscopy, and this is one of the risks of going to do the surgery and then you will find nothing. So you have to inform the patient that there is 1/3 of the cases the finding will be negative. Don't forget the latex allergy. The patient has to be the first on the list. The theater manager has to be informed to distribute the information, inform the anesthetist responsible for the case, availability of latex-free trolleys and cart and emergency medication, latex-free equipment and instruments and gloves and syringes. Here the examiner may come out and ask what are the entry techniques as a prompt point if you didn't mention it here, and then he will ask you what you will do if you find endometriosis. Your answer will be, it depends on the patient consent, it depends on the type of endometriosis, but biopsy has to be taken in each case to confirm the diagnosis. So this is a way how to answer the case. This is a way how to approach the station case by case. We will continue the other cases in the practice session. I will announce in the group, inshallah. So thank you very much. And please, if you find it useful, please remember me in your prayers in this holy month. Thank you and good luck for everyone.